Hi there. I will be discussing a machine learning-based approach to classifying a provider's description of chest pain. Many patients present to an ER with the chief complaint of chest pain. We wanted to see whether we could use AI to differentiate between cardiac versus non-cardiac chest pain, purely examining provider notes. The last few years really have seen major advances in NLP. At the heart of that has been these transformers, which we'll talk about a little bit. We wanted to see whether firstly, whether AI-based approaches can differentiate between cardiac versus non-cardiac chest pain. We also want to see whether the more novel transformer-based techniques might offer a better tool than the more traditional approaches. Um, we got our data from Mimic. We started off with many, many notes. We whittled that down to 837 unique descriptions of chest pain with an associated first-time troponin value that was obtained within 6 hours of the note. We wanted the troponin to come out after the note. We didn't want the provider to theoretically be aware of the troponin, ideally. Um, these notes required a high degree of preprocessing and filtering, which is usually the case with NLP. Um, we looked at the more traditional techniques that included TF-IDF, bag of words, and then an ensemble approach, including naive Bayes, logistic regression, SVC, and random forest. Then we looked at the more novel transformer-based techniques, including BERT, Roberta, Distil-BERT, and Clinical BERT. And all models were tested according to AUC, MCC, and F1 score. This is just a sample text, just to give you a bit of a sense of what these notes look like. The note length, generally, this is just generally a histogram of the number of words in each of the notes. These are the most common words, nothing too unexpected here. This is a histogram of troponin values that were obtained. So of the 837 unique instances of chest pain in these notes, 273 were associated with clinically significant elevated troponin, which we consider to represent true cardiac chest pain. And these are some of the performance values that we got. In general, the top two rows, you could see LR and SVC seem to perform decently well. Looking at the more novel-based, transformer-based techniques, you can see kind of across the board, these are performing quite well with F1 scores and AUCs in the low to mid 90s. Just looking purely at the coefficients of words and whether words are more likely to be associated with cardiac versus non-cardiac chest pain, you can see words like STEMI, NSTEMI, and PLAVIX seem to be more associated with cardiac pain, whereas words like GI and EGD are more non-cardiac chest pain, which is kind of what we expect and does give some merit to the approach we're taking here. There are certainly many limitations to this project. In our mind, we really just wanted to see whether there was any sort of signal here, and if there was, then the idea was we would deploy a similar approach towards much larger data sets with more fine-grained sets of clinical classification schema. And that's it. Thank you.